Overall,
ഹായ് മീറ്റി, തുടങ്ങാൻ തോന്നുന്നു. ഞാൻ എന്തായാലും റെക്കോർഡ് ചെയ്യുന്നുണ്ട്.
ഓക്കെ, സൺഡേ അല്ലേ ഇന്ന് എല്ലാരും
അപ്പൊ
കുറച്ച്
അതൊക്കെ ജോയിൻ ചെയ്യുമായിരിക്കും.
ബിസി ആയിരിക്കും. ഓക്കെ. Hello, good afternoon. Today we'll have a small session on pulmonary rehabilitation and home care. I assume that both of you have finished or almost you're finishing your course and you're aspiring to write the exam for DOH. So we'll not go very detailed into each topic, but we'll see an overview of these two topics. Okay. Okay, so we know that chronic respiratory disease it causes a lot of economic burden to the governments taking care of patients who have long-term disease processes. So chronic respiratory diseases it is a cause for high mortality in the world, and it is also a cause for high expenses in terms of medical care as well. We are aware of that. So, what is pulmonary rehabilitation? Pulmonary rehabilitation is nothing but a combination of exercise training, education, and behavioral support in from different point of view, for a patient with chronic respiratory disease. So it is basically something that we do as a multidisciplinary process where many different therapists come together and they assess a particular patient. They then after assessment they chart a particular treatment strategy for that patient. So it's a specifically tailored therapy for each different patient as per their need. So what we will be doing is we'll be supporting, first of all we'll be assessing the patient. We'll try to understand what is the patient's issue. We'll see how much the patient understands the situation, what problem the patient has, the extent of the disease process, the need for different therapies to improve their condition. So when you talk about therapies, it includes physiotherapy, respiratory therapy, occupational therapy, and sometimes support from the psychological point of view as well. And after the exercise training, you will be um, reassessing the patient, and you will see if they need the training for long term. Most of the times it is a long term process and a continuous process. So this comprises of pulmonary rehabilitation. So it is basically a therapy that is tailored for each patient, and it includes exercises, education, and psychological support as well. So, if you see different guidelines, most of the guidelines, if it is American Thoracic Society, or if you look at the British Thoracic Society, all of them, even though there is only moderate to low quality evidence, they recommend pulmonary rehabilitation for most of the chronic respiratory disease patients, especially COPD patients. Even though the evidence wise, it is not very strong, except for patients with COPD, um, uh, with exacerbated COPD. But for others, it's not really strong, but they still recommend pulmonary rehabilitation. It can definitely not cause any harm to the patient, so they recommend that the patients should go ahead. get pulmonary rehabilitation, whether it is at home or whether it is at a center. So as per the disease condition, it is recommended for them to um, pursue pulmonary rehabilitation. So what are the common chronic respiratory diseases that for which we indicate pulmonary rehabilitation? The most common disease is the obstructive diseases such as COPD, persistent asthma, bronchiectasis, restrictive diseases such as interstitial lung disease, scoliosis, any skeletal deformities, patients with neurological disorders which come later in life, Parkinson's disease, then patients who are having acute forms of problems also, lung cancer, maybe post-op, they need some rehabilitation. Maybe there was a pneumonectomy done, and then, following which rehab is required. Pulmonary hypertension, before and after transplantation, all these are indications for pulmonary rehabilitation. Well, this is a very short list. More patients, more chronic respiratory diseases are there in the list, but these are the major ones where you would be providing pulmonary rehabilitation. And then there are certain situations where it is contraindicated, of course, if the patient is not stable, vital signs wise, if there is any situation where you could harm the patient with rehab, then it is, of course, contraindicated. So when you look at pulmonary rehabilitation includes the first is the patient assessment, right? So patient in assessment itself, you have different angles of assessment. You can say from multidisciplinary point of view, therapists from multiple departments need to assess the patient, because most of the time it is not solely a respiratory issue. It could be something else which is making the patient it's like, if there is a muscle issue, patient is unable to um, use the muscle properly, making them difficult to move around, which makes them put on weight, they cannot move even more, it gets even more worse, and then it becomes a vicious cycle where because of the weight they cannot move at all, and then it is still continues. It's not just muscle issue, it could be um um, any other issue as well, which needs, that's why it needs to be, the patient needs to be evaluated by a occupational therapist, a physiotherapist, respiratory therapist, and a dietitian. Maybe patient requires psychological assessment as well. All these people need to assess the patient. So we'll see these assessments one by one quickly. So first of all, we have to see the medical history of the patient. If the patient has any respiratory history, or if the patient's family had any respiratory disease history, um, if the patient is on any medications currently, or he was on any medication in the past, if there are any allergies, drug intolerance, if there is a smoking history, which is very relevant when it comes to respiratory rehab. So then other than that, you have to see if patient had any occupational exposure, such as workplace exposures where they tend to inhale fine particles, or fumes. If the patient was, for example, in the painting industry, like painting job, they tend to inhale a lot of fumes. If they are in construction, they tend to inhale a lot of fine particles. So when you say construction, it is not limited to construction workers, even owners of these construction companies, they go to site a lot, even the bigger people, they also get exposed. So I had a patient prior, he passed away already. He owned a construction company here. I mean, he owns it. And then um, he developed interstitial lung disease later in life, well into his 80s. But the reason is because he used to spend a lot of time in the construction sites in his younger age. So he went ahead and he developed the disease. Finally, he was on ventilator, and then at some point, when it was more like palliative care. There was nothing other than lung transplantation, and he was already late 80s, so that was not an option for him as well. So that is one history that if there is, then you can expect respiratory issues. If there has been any substance abuse, and if there is alcohol usage. So these, not limited to these, but these are the major things that you will take in medical history. In the physical examination, of course, you will see the vital signs, you will get the height and weight, you have to do the chest examination, inspection, palpation, percussion, auscultation. As a respiratory therapist, you will be doing all this. From if you can pick up murmurs, then well and good, but from the file, otherwise you can get a history of any heart disease. If patient, whether they have peripheral edema, you can check jugular venous distension. If that is present, you can understand that patient probably has some congestive chest. So you can assess that. Then if there is presence of clubbing, then you have to do the upper and lower extremity evaluation. Basically, upper and lower extremity evaluation, the physiotherapist might help you to do that. We are not trained to do that as respiratory therapists, but at the same time, you can understand whether the patient has a good amount of muscle or not for you to go ahead do the rehab. If you need to, if you see that patient is very thin, doesn't have muscle mass, then that you need to send the patient to the first of all the dietitian, nutritionist, or the physiotherapist, so that you can support the um, um, so you can support the training of the extremities, so that it will help you in patient recovering from the respiratory problems easily. Then signs of if the signs of any vascular insufficiency, joint diseases, musculoskeletal dysfunction, all these things you can check by physical examination. Then another thing that you would be doing during assessment is the diagnostic test. So that is the basis for us. We do the spirometry usually, the basic one, or if more complicated ones need to be done, you can go ahead do that one. You can do a bronchodilator, reversal. You can go ahead do other tests to see if there is any issue with gas exchange, or you have the DLCO, and you have the methacholine challenge test. All those tests, simple or more elaborate tests, you can go ahead and do if required. Then you check the saturation at rest and during exercise. Then chest X-ray, ECG, 6-minute walk test is also done to diagnose. 6-minute walk test is done as diagnostic test, as well as to see if patient has improved. Also, like after post pulmonary rehabilitation, you can use it as a baseline, the one before and after, to see if there is any positive effect of your rehabilitation process. Screening for depression, anxiety, this probably you can refer if you think that patient is there is a need for evaluation. You can direct them to the appropriate department. Then you do the basic blood test. Usually the physician will be the one who will be recommending all these tests plus the complete blood count as well. You have to do the assessment of the symptoms. If patient is having dyspnea, whether the dyspnea is at rest, whether it is at like it's exertional, whether it is only at night, whether it is only during lying down or getting up, all those things. Dyspnea different types you can assess and see. Then if patient has fatigue, cough, if they have sputum, what is the type of sputum the patient has, the color, how much, like volume, consistency, if it is smelly, how often the patient gets sputum production or cough in a year, all those histories you have to find out. Then you do the exercise assessment. Basically, other than the 6-minute walk test, I think rest of them would be done by the physiotherapist. They will be able to do the proper assessment and give you an idea. Like you will be sitting together and actually forming a rehab schedule for this patient. So the physiotherapist will be the one who will be doing the exercise assessment. Exercise tolerance you can also do with spirometry. But other things like extremities, muscles, like the physical activity of the patient, those things would be assessed by the physiotherapist. Then pain assessment. Pain assessment also should be done, because if the patient has pain, there is a tendency for them not to move at all or do anything that will cause them pain. So if there is pain, then it has to be taken care of before you start rehabilitating the patient. So pain assessment is important. One of the pain assessment scores that we used to use was FLAC. So you see the face, leg activity, cry, consolability. There is FLAC and there is modified FLAC for pediatric patients. So you will be doing this pain scale, and if there is pain, then you have to also um, send them back to the physician and see what you can do about it, because if there is pain ongoing, then you may not be able to effectively do the rehabilitation process. It has to be managed somehow. Then activities of daily living assessment. Even this one, basically it's a combination of physiotherapist, nursing, and respiratory therapist assessment. So the breathing techniques, activities of daily living, how much they are able to do the activities of daily living, how much like breathing difficulty they have during activities of daily living. Like if they are panting with every time they get up, they cannot eat their food, they cannot hold their spoon to the going to the mouth, going to the restroom, they need help, all those things, assessment has to be done. So that's also part of the assessment process. The nutritional assessment will be done by the dietitian or the nutritionist. What is required, what is lacking, what has to be added, if any um, restrictions should be placed for this particular patient, especially with certain medications, what should be had, what shouldn't be had, what should be had separate, some medicines should not be mixed with certain foods, all those things can be discussed with the nutritionist. And the calories also very important. If the patient needs to bulk up, they need and have the energy, they need calories, they need proper fiber, all those things, um, fat content, all those things. They would know what to recommend for the best of the patient, for the muscle, bulking up and all those things. Bulking up in the sense not like weightlifting, but for them to recover from the muscles that they have, which has become, the muscle attrition, whatever has happened, that has to recover. Then the assessment you do is the educational assessment, whether patient understands that he has the disease, how much he knows about the disease. If not, you have to explain to the patient the about the disease, the severity of the disease, if they understand, and the treatment that is required for this particular, if they, disease, that they should understand. Most of the times, um, especially in our place, we talk in English. Our sometimes our postgraduates or doctors, they're not from our, they don't speak our local language, they end up talking in English. So this is not conveyed properly to the patient, and they do not know what is happening. And when they don't know, of course, they don't understand why they need a particular um, exercise or rehab process. And that would probably, there's a gap there, and they would go home, and then they again, something that can be solved with simple exercises and stuff is not done, and the patient struggles to do the activities of daily living. So the knowledge of the disease is important, the language barrier, the understanding of the patient, if the patient has the cognitive ability to understand. So if somebody who doesn't have a cognitive ability to understand, then their bystander should be able to, you should be able to communicate with them to convey what is happening. If they do not understand, you go and tell them, it doesn't make any sense. If patient can, the vision, all those things matter. So this assessment also should be done. You have to make sure that patient understands why we are doing the treatment. Otherwise, that would help to encourage them to do the exercises and take their medications on time. And if consistency is something that is very important in pulmonary rehabilitation, if they don't understand what is happening, probably they will not understand the importance of being consistent and do the exercises and do the process regularly. So then there is no outcome. The outcome is not good if they are not consistent. Then psychosocial assessment, usually this will be done by the clinical psychologist or um, the psychiatrist, but I think they'll be the one doing this assessment. If any patient is having any signs of anxiety and depression and all that, that also has to be taken care, because then there won't be, if otherwise, there is no motivation to to undergo the rehab process. Now, um, when it comes to respiratory therapists, when you look at rehabilitation, for us, mainly, pulmonary rehabilitation actually involves a lot
Audi.
of muscle training, right? It is very important to do exercises, physical exercise. Um, and not very like aggressive exercise, but what you're trying to do is you're trying to rehabilitate or um, get the muscle to get stronger, so that the patient can overcome whatever debilitating, whatever that is stopping the respiratory or making it difficult to breathe, can be supported by the upper extremities and your muscles. It can overcome that difficulty, and it will help to overcome that difficulty. So basically, those things has to be done by the physiotherapists. Activities of daily living, how to go about, activities of daily, those that also, basically falls under nursing and occupational therapy. For us, respiratory therapists, what we concentrate mostly is on, first of all, is the breathing exercise. That is something that, um, very important, that we can contribute. Then the clearance techniques that we do to get the phlegm out, the medication management, so the respiratory medication, nebulizations, MDI, all those things, if the patient knows the correct technique, how it is done, that part has to be taken care by us. Now, MDI and all, it is very complicated, the synchronization and all those things, um, breath holding, all those things, very difficult. So you need to, talk to them, see if they're using it in the proper way, introduce spacers, um, make sure that they take their medicines on time. It is very, very difficult to get them to take medicines on time. Even my mother, she's on inhaler twice a day, but if nobody is looking, she's going to just skip the medication if possible. And then, next day she'll be more wheezy, and that's when she'll take. But once you are wheezy, and then at that point, if you take, it takes time to control the wheezing. So, because it's a chronic disease, it should be taken on time, and then only the maintenance, the ease of breathing will be maintained. Unfortunately, it is a bit difficult, so somebody has to really watch them, if it is especially if they are of the older age group. Another thing that as a respiratory therapist you can contribute is um, managing the airway, right? If the patient has tracheostomy, if the patient is using BiPAP, or that also actually falls under respiratory therapy. If patient is using their machines, non-invasive machines, how long they're using every month or two, they you'll call them to the clinic. You have to make sure that you have the memory card read, the report, how often they are using, how long they're using every day, whether if it is very short, then it will not be good for the patient. Those things are the things that as respiratory therapist you can actually concentrate when it comes to pulmonary rehabilitation. Okay. um, Now, there are different lab and field tests that you would also do. If you're working in PFT labs, you will be doing these testing. You'll be doing 6-minute walk test. There is just a step test, 1 minute sit and stand. There are many tests actually. I will actually share this a link with you. There is explanation for each test, and you can read about it. So these things, not practiced very often in our place. But if you are working in a dedicated, I think your pulmonary in Amrita, definitely there is a good pulmonology department. Probably there, um, for like they are following all this wherever you're working or wherever you're studying. If you have the opportunity to do all this, it's very good. But not every place has this, so you can just read it once for the exam, because you never know what will come for the multiple choice questions, right? So you have to be aware of these tests. Now, moving on to home care. So, home care actually is a vast topic. So, here, home care, I've just taken slides from one of my previous talks. That was on home mechanical ventilation, basically. So, I have included other things in this so that everything is covered. So, home respiratory care is a big thing here actually in the UAE, because you're going to write exam over here. But at the same time, the questions that might come for your exam will be more acute setup oriented. But we'll just go through this so that nothing is missed. Okay. But it is a huge industry here, home respiratory care. We have plenty of patients on ventilator at home, plenty of patients on oxygen therapy at home, tracheostomy at home. Um, because of the availability of insurance and stuff, they are able to maintain these patients at home effectively. So, who goes home basically? So, patients on oxygen therapy, tracheostomy patients, mechanically ventilated patients who are stable for months, they do not require any change in respiratory settings, or the oxygen requirement has not changed much. Those patients can go home on the same therapy. Okay, they'll receive the same therapy at home. So, what are the goals of home respiratory care? Um, see, the first basic goal will be to increase survival. All these things that we do, we give oxygen, we give ventilation, we give everything, is to increase survival. So that is the first basic goal. Second is to improve the quality of life. That is the main, you can say, the plus point of going home, because patient gets to stay in their own house along with their family. Even though they are chronically ill patient, they're on machines and they're on oxygen and everything, but to some extent they can maintain their normality life, they can live their normal life in their own bedroom, in their, with their family. If not, if they cannot eat with them, but at least, they can sit together while they eat, things like that. So it improves the quality of life. It makes a huge difference. Even if, we get admitted a couple of days in hospital, you feel miserable, you just want to go home, and you come home, you lie on your bed and you already feel better. So imagine chronic patients. So going home improves quality of life. Then reduction of incidence of infection. That is another aim that we fulfill when we send patients home, because in the hospital there is chance for a lot of different infections. So at home, to a large extent, it can be reduced, the incidence of infection. In children, you promote optimal growth and development. Basically, you are maintaining them at home, so they grow and develop at home. There is a group of patients who would go for home care, who are terminally ill. You know that they're not going to recover. So that would be that falling under palliative care, where you are going to just support the patient at home. So they get to, die at their home, or they can be there at home, taken care at home for the longer, as long as they are alive. So again, for home care, there are a group of, like, a list of diseases that, you can see, patients who are falling under this list usually, go home with the, medical team, with the care that they require. So I have divided this into different disease types, actually, all these different diseases. So the first one is medical conditions with skeletal disorders. So patients who are having scoliosis, kyphoscoliosis, other certain syndromes, one example is Charcot-Levin syndrome, where the patient has a problem with the rib cage. Then you have CNS issues, patients with CNS issues, stroke patients, very common post-stroke. They will have difficulty breathing, they will have muscle weakness. Some of them lose their ability to cough. So if they cannot cough, they cannot maintain their airway. They'll need an artificial airway. They might need oxygen, may not need oxygen, may need ventilation, may not need ventilation. So stroke patients, very common for home care. Patients with spinal cord injuries, so patients who are paralyzed, do not have respiratory efforts, on ventilator usually, or off and on ventilator, those cases also go home on ventilation. Then congenital issues, patients who are having issues with breathing, um, they're not breathing adequately from birth, those patients also may go home with a ventilator, or with oxygen, or with an artificial airway as well. Then other neuromuscular disorders, such as spinal muscular atrophy, amyotrophic lateral sclerosis, myasthenia gravis, Guillain-Barré syndrome, phrenic nerve paralysis, all these cases can be supported at home, provided there is a good respiratory therapist watching them. Cardiovascular disorders, patients with congenital complex heart disease, heart failure, respiratory disorders such as obstructive COPD patients, very common on ventilator, long-term ventilation. We all know that once they are, when they are older, especially when they are, you try to avoid intubation, right? Why do you try to avoid intubation? Because you know that once you intubate, it is very difficult to extubate them. So you avoid intubation. So if once they are on the ventilator, it's very hard to completely get them off vent. So that COPD on ventilator is also very common at home. Then you have COPD patients with oxygen also at home with BiPAP machines, CPAP machines, non-invasive ventilation at home. All these are common diseases, ILD, tracheomalacia, upper airway stenosis, patients with tracheostomy tube because of airway issues, pediatric patients. All these are very common cases that go home with respiratory care support. So those are the diseases, that can be managed at home. But can every patient with these diseases can be managed at home? No. There is certain criteria that these patients should fulfill for them to um, be qualified to go home. Actually, the first and foremost is they should be hemodynamically stable. They could be on medication for blood pressure, but not on inotropes. I mean, if they're on tablets and all, it's okay, but not on inotropes. So patient should be hemodynamically stable. No desaturation every now and then. All those things, all those cases cannot go home. So patient should be basically very stable for the longest time before they are considered to be sent home. They should be on a single ventilator setting or two, maximum two settings, where one is a primary setting where it is maybe full support, and then there is a secondary setting with a difference. Maybe patient is on spontaneous modes in the daytime and full support in the nighttime. But basically that you don't go up and down respiratory rate, go up, go down, go up, go down as per the need of the patient. That should not happen in home care. That is for the hospital, where you need to tweak every now and then. Different settings, you place different settings, patient require different settings. That is a different scenario that cannot be managed at home. At home, they should be on a stable setting. Of course, when they fall sick, you might have to change, but at that point, patient should go to hospital. And that means, because they are sick, they need more care. Maybe they need a chest X-ray to see what's happening. They need antibiotic can be given at home, but probably they need chest X-ray to see what is happening. Maybe something else is going on, with the patient. So that means they're not stable, so they need to go to hospital. And also the requirement of oxygen should be below 5 liters. So 5 liters, approximately 40% of oxygen, should be the criteria for the patient to go home, except for patients on palliative care, where patient might go home on higher oxygen support, because the mm, the idea there is, the goal there is different, right? You are not going to treat the patient or maintain the patient. You are just going to make the patient comfortable until they pass away peacefully at home, right? So that is a different scenario, where you will accept with 100% oxygen. Also, you have to arrange multiple concentrators, big oxygen tanks and stuff, and send them home. So you see, these are the criteria for covering to fall under patients who could go home. And then once they qualifies for going home, there are certain requirements, discharge requirements, that should be fulfilled. First thing is, the patient house should be assessed to see if the patient house is okay for the patient and can maintain the patient. They have to have a different room. Patient has to have a different room with all the necessary equipment available, good power, plug point, plug points should be available enough, adequate. Then also patient should be ideally on the ground floor, so that if there's an emergency, patient can be evacuated easily. There are certain circumstances where you can't do that. If the house is not on the ground floor, you have to, or maybe there are no bedrooms on the ground floor. Patient might have to be kept, but in a different level. But it is very difficult to evacuate them in case of emergencies. When they fall sick, especially, it is very difficult for the ambulance crew also to take them to the hospital. So house assessment should be done first before discharge. Training should be done for the nurses and the caregivers. Respiratory therapists usually what they will be doing is, of course, they don't need any training for equipment, but if it is a new equipment, you can, that you have not used before, while the patient is preparing for discharge, you can talk to the hospital RT, and if you need in service training, they will give you explanation of the mission if ever you need that. So that is the system here. Um, then competency assessment for nurses for the respiratory care will be done by the respiratory therapist. It should be done because you're not going to be there in the house of the patient all the time, but the nurses would be. So you need to make sure that they're trained in chest physiotherapy, suctioning, postural drainage, all those things, ventilator alarm management, basic ones has to be. They should be able to tackle it, and you should train them in that. So, and the family also should be trained in processes such as tracheostomy. Like if the patient decannulates accidentally, they should be able to recannulate, put the trach back. So that training has to be given to the family. Also, basic life support training should be given to the nurses and family. So initial home visit, you do the assessment of the house, you make sure that all the equipments, everything is available. Patient, if they're on oxygen therapy, make sure the doctor gives you an order. Um, you have to make sure that there are signages saying that oxygen is in use. Nobody should be using any open flames near that room. No smoking allowed, not for others, not for the patient also. Um, uh, the chronic patients usually smokers, they are very difficult to manage. We have had patients where, you go to the ward to give them pulmonary rehabilitation, and the nurse would tell you, the patient stepped out to smoke. You have to wait for him to come back. So that is the situation. So you have to make sure that you explain the dangers of smoking near oxygen um, dispensing devices. Okay. So the oxygen delivery devices that you use at home are usually low flow devices. You don't use fixed flow devices. You would be using simple things, nasal cannula, simple face mask, the Swedish nose thermovent, the small HME that you use with the tracheostomy, or a tracheostomy mask. All these things, very simple to use. Oxygen delivery devices. You don't use high flow devices. Because you don't have a high flow oxygen system also, I mean high pressure oxygen system also, you can't use any of those. You would be using only these simple devices. Even the ventilator, they work on low flows. They have compressors basically inside the ventilator which will build the pressure, and oxygen is supplemented as flow separately. Okay, so all low flow devices. The other extra devices that you would be using at home would be devices that would help you help the patient to expel the tracheal secretions, right? So you have a vest which vibrates. It's like a shirt, or it's like a small um, um, sort of like a wraparound, and it vibrates and it helps to expel the secretions. Or you might also use the handheld percussor, which will also help to remove or dislodge the secretions. And there is insufflation, exsufflation machines as well that you can use with the mask or a trach as well. So if your patient is on tracheostomy, then you need to know, and also the nurses should be very much aware of the tracheostomy type, the type of the tube, the size of the tube, when was it changed, when it is due to be changed, all those things, and how to manage emergencies during decannulation, during block, all those things. Okay. The regular changes usually are done in hospital or by the RT if it is at home, if it is safe. If it is safe for the process, it's for the patient. It's not same for all patients. Some patients it is difficult to change. Some patient it's easy to change. So usually the doctor will give a recommendation if it can be changed at home. Still, if you don't feel comfortable, you can send the patient to the hospital. So there are some, if your patient is on ventilator, you have to make sure that there is a backup plan for this particular patient, like backup ventilator. If the ventilator is not working, what are you going to do? What is the backup plan? You plan, because you can't send you can of course send the patient to the hospital, but you're going to um, your home care is not going to get the money. So you need to have a backup ventilator, and also it is safe for the patient if there is a backup ventilator. You can just switch from one to another. Also for the different alarms, how you're going to deal with it. So this is the particular alarm troubleshooting that we used to use in our office, in our center. And the goal for home care would be basically to avoid hospital admission. Okay. So what you're going to do is you're going to make sure that the equipment that you use are clean, the supplies that you use are clean, the processes, the procedures that the nurses or you are doing is sterile, all those things, the training, retraining, checking again and again and again. All these things are part of our work in home care. Okay, it's very challenging to work in home care. But at the same time, if you can maintain the patient at home in the comfort of their home, that is the best thing that can happen. So we just have, I think, only a few minutes left. We'll just go quickly through few sample questions that I've prepared here. Um, I don't know how many of you are currently here. So if you know the answer, please um, open your mic and you can answer. So which of the following is the primary goal of pulmonary rehabilitation?
Option 2.
Okay. Yeah, you're right. So it's to improve the physical endurance and reduce symptoms. So other options here is to cure chronic lung disease. So I don't think chronic lung disease curing is the goal for pulmonary rehab, and curing, I mean, chronic lung disease, it's going to be there, right? You can't really 100% cure it. So that is out of question. To replace pharmacological treatment, that is also not our goal. It's not to stop any medication. Maybe your rehab can improve and reduce the dosage, but that's not our goal. Also, to increase lung volume regardless of functional improvement is also not our goal. Our goal is to increase the functional capacity of the patient, right? So those three are definitely not the answer. So the answer is to improve physical endurance and reduce the symptom. You're right. Which of the following conditions most commonly benefit from pulmonary rehabilitation?
COPD.
Okay, very good. So I think that is a clear answer there. Um, Third question, what role does education play in pulmonary rehabilitation?
Option 2. It helps patients understand their disease and self-management strategies.
Yes, you're right. So basically, it's definitely not for health professionals alone. It's not only for our understanding. The most important thing I've also explained before, that the patient should know there's a disease process, the severity of the disease, so they can also understand what to do about it and manage at the right time. For example, if a patient is assessing themselves at home, if one day they think that their um, uh, the capacity is less, so they can go ahead, increase their medication, and they can manage, right? So you're right, it helps patient understand their disease and self-management strategies. Question 4: a patient in pulmonary rehabilitation complains of dyspnea during exercise. What is an appropriate initial response?
Option 1,
Yes, you're right. So you increase oxygen flow to help alleviate symptoms. So this is a little there are two options that you might feel is correct. The fourth one: assess the intensity of exercise and teach
exercise
breathing
or
technique to
patient.
elevate.
Mm.
Yeah, so those two seems like uh, appropriate things to do, but definitely when the patient has dyspnea, you can what you do first is you manage that symptom.
Treat management.
And
Mm.
yes, and correct. And then you reassess whether
Mm.
the intensity that you're doing is too much for the patient. So you probably need to reduce a little bit and then slowly increase the intensity as the patient can manage. Also, like you will also teach them like pursed lip breathing and all that, to manage what they're going through. If they are dyspneic, how, if they walk a little bit, they're dyspneic. So you tell them, purse your lip and breathe so that they can recover faster also. So basically, 1 and 4 are more, they are both correct, but initial response would be to increase the oxygen flow. Next question: which outcome measure is commonly used to assess the effectiveness of pulmonary rehabilitation?
6 minute walk.
Yeah, so 6-minute walk test. So I think pre and post, if there is a difference of 60 meters,
Mm.
it is considered as improvement. But then, there is criteria for different diseases. 6-minute walk test, there is different for pulmonary patient. There is different criteria for cardiogenic patient, different for ILD. So you need to see the guidelines. What is the minimum oxygen supplementation criteria for home discharge? Sorry, maximum. The question is wrong here. What is the maximum oxygen that supplementation you can consider before going home, like for going home?
Below
Maximum
5
oxygen.
liter,
Yeah, below 5 liters or 40% is the safest level that is recommended for the patient to go home. We can manage them better because, the oxygen tank capacity, the concentrator, usually you have two different oxygen concentrators available in market. The most common one which we use is the 5 liters one. 10 liters one is pretty expensive, so they are not usually dispensed also. And that above 40% is, you consider, even in hospital you consider it as a high oxygen
high
supplementation.
oxygen
So,
supplementation.
yes, so it is, they are not it's not recommended to send them home. Okay. Question 7: what is the major goal of home care in chronic lung disease patient?
Okay. To increase the quality of life in long-term patients.
Yes, it's a very simple question. So, to
Mm.
increase the quality of life, um, the another option here is to stop all medication and start alternative therapies. No, that is not the goal for
Possible.
home care.
Mm.
That would be just a choice if the patient has to. What is the recommended cleaning frequency for reusable nebulizer cups and masks in the home setting?
After every use,
Yes, you're right. After every use. So all these nebulizers, all are one-time use, basically, right? We don't have reusable ones currently. I mean, there are reusable ones, but if they are like connected already in line in the ventilator circuit and all, you can reuse. But like aerogen and all that. But there is still, I don't think, it's very commonly used in home care setup, especially. The other kind that we use, the small volume jet nebulizer, they are actually one-time use. So one-time use meaning you use it and you throw it. But the thing is, in home care, again, it's not possible. So here in the government hospital here, the policy, what, they are asking home cares to follow is um, to, wash it or clean it after every use and to replace it every week. Um, uh, that's what is followed here. A patient using a home pulse oximeter notices their saturation to be consistently below their target range. What should be the first action?
Uh, it's, the device is certain, but he is not having any problem with it or not. Increase their oxygen flow rate significantly.
Okay, so um, yeah, these are chronic patients, right? So
They
increasing, oxygen flow rate, maybe your second step if it is needed, right? So you
recheck,
should always,
recheck the
you
reading.
should recheck. Yeah.
Okay,
So that should be the
okay.
first thing. You
Uh,
recheck and
uh,
make sure, because in acute patients,
Chronic
maybe,
patients,
yes,
yeah,
acute
chronic
patient
patients, it
also
will be
they would
same.
say, yeah,
Mm,
even in acute patient, they would say recheck, because, that's what we
okay.
do, right? We always
Uh,
ask to recheck,
reach.
because they are bed-bound patients and all. Usually, cold extremity or, the probe to come out is quite common. So you recheck. Then, if you second step would be to increase oxygen
Increase the
if
oxygen
required.
rate. Okay. Okay, ma'am.
And the last question, which of the following is an important aspect of managing secretion at home for a patient with chronic respiratory condition?
Encourage adequate hydration and performing airway clearance techniques if prescribed.
Yes. So encourage adequate hydration and performing airway clearance technique if prescribed. So this is very commonly, you don't hear it in hospital setup. I think you do actually, in even in ICUs, they will increase the, hydration and all that. But at home, especially, this is something that I have always heard from my colleagues is that, whenever there is secretion which is thick, they increase the hydration. Or maybe I just concentrated more because, in ICU setup, maybe I'm not thinking from, that
Mm,
perspective when a doctor says. But this is something, even the patients who could talk, who are on ventilator and all, but who could talk, the doctor used to always tell them, you increase your water intake, have more
mm,
liquids, especially winter time. They, patients who are okay rest of the year, in winter, they will have very thick secretions. Of course, there will be a little bit more wheezing and all that. So usually at that time, we tend to change the like regimen little bit, with the bronchodilators. And if needed, we add a more saline, normal saline nebulization and all that, just to increase the hydration, because they would be already on humidifiers and all, but sometimes that is also not adequate and it happens. Yeah.
mm.
Okay. So I think we are done with the class here. Um, um, if any doubt, you can ask now.
No, ma'am. That was okay, ma'am.
Thank you, Meeti. Thank you.
Thank you, ma'am.
Thank you,
I
ma'am.
Yeah, thank you. I will send the video to everyone.
Okay, okay.
Oh, thank you.
Okay, ma'am. Thank you. Bye.